I'd like to talk to you today about evaluation of simulation. This is a topic that's really become increasingly important over time as we've learned more about simulation-based learning and how it impacts our learners and outcomes. There's no doubt that simulation is effective, but it's also expensive and it's time and labor intensive to implement. So it's really important that our efforts and subsequent outcomes be evaluated. At the end of the discussion, I hope you'll have a clear understanding of different aspects of the simulation-based learning experience that should be evaluated, what tools can best be used for those evaluations, and how to determine if they are valid and reliable. I'll discuss the use of the NLN-Jeffries theory to help determine what aspects of simulation can and should be studied, and then share with you information about existing tools that are available. I'm going to also talk about the reliability and validity of these tools, and then there will be a reference list available for more articles about each of those tools if you're interested. So since the beginning of simulation use, there's been a great deal of interest in how learners respond to this teaching strategy. Historically, it's been more important to know whether the learners like the experience of learning with simulation than it has been to know how they learn, why they learn, or to what degree they learn. Now, this has always interested me because we haven't really cared much about how they liked our other teaching methods. Dear student, did you like when I used a case study today? Should I do that again? Did you enjoy that I used PowerPoint? Of course, the reason we ask these types of questions about simulation is directly related to the expense. Now, many educators have relied on satisfaction surveys and questionnaires to evaluate their simulation programs, asking questions such as, did you have fun while learning with simulation? Did you enjoy this learning experience? And would you like to come to the simulation lab again? Well, overwhelmingly, the learners told us that yes, they like simulation, they want to do it more often, and sometimes even that it was their best experience in school. Now, there's always a couple in each group that don't quite feel that way, but overwhelmingly, the answer is yes, we're satisfied and we're happy. But what does that really mean? Why are the learners satisfied? Well, there's a lot of different reasons that learners can be satisfied. Class finished early. I was in a class today that ended a half hour early. Everybody was happy and they were satisfied. Now, the teacher was funny. Well, comedy can lighten the mood and the level of anxiety for learners in simulation, but there are a lot of pretty serious topics that are addressed as well, and that can lead to increased stress and anxiety amongst the learners, and they don't typically like that. Others are glad to have spent time with their friends. While a good number of students do recognize that they have learned a lot during the experience that they can then apply to future care of real people. But let's look at the reasons why people are dissatisfied. Well, maybe everybody didn't get to spend time with their friends, or they didn't much care for the other people in their group, or maybe the teacher was disorganized. Sometimes that can be really distracting to the real purpose of the teaching. We've all experienced classes where we had no idea what the teacher was talking about or the point they were trying to get to. Now, dissatisfied learners often tell me that one of the reasons for their discontent is they just can't get into talking to plastic people. They struggle to suspend disbelief in a way that allows them to buy into the experience. And, I'm tired. I hate getting up this early, to go to class. That was always my excuse. But what we did not learn with these surveys is whether the simulated learning activity impacted outcomes in a meaningful way. Was knowledge increased? Critical thinking and clinical judgment improved? Did learners prioritize differently as a result of the education? And most importantly, were they able to transfer what they learned to the traditional patient environment? One of the reasons that early research focused on satisfaction is that we were really just learning about simulation. We barely knew how to turn the simulators on and off, and we just had an inkling about its potential. We had to learn about simulation before we could figure out how to study it. But there is a use for that satisfaction information. It's really valuable information to gather in support of simulation. to then be used to gain buy-in from reluctant faculty. See, the learners love simulation and want to have this opportunity in every course. So how can I help you to use it in your course? It's also valuable when you're meeting with other stakeholders, particularly those with private funds. Now, donors want to know that their money is going to good use and is supporting improved learning. But honestly, they also want their money to go to something that's going to be used. So showing quotes and data directly gathered from students related to their satisfaction really is important to share with these stakeholders. But it's just the tip of the iceberg and really should be followed up with outcomes-based findings. However, journal editors, not so much. They won't publish study findings that are only related to satisfaction anymore. They want the higher level outcomes. They will publish these results as part of a larger study, but for the most part, satisfaction has been well covered in the literature. Now, what about perceptions? How do they fit in? Now, you've heard the saying, perception is truth. I'm not a really big fan of that saying because just because somebody perceives something a certain way does not mean that they're right. But in simulation, there is the opportunity for several perceptions or truths to emerge. So let me explain. Here's a picture of a simulated patient room. Seems pretty straightforward. A small group of learners enters the room to provide patient care. The facilitator and lab tech observe through a one-way mirror. Everybody sees the same thing, right? Well, oftentimes when providing care in simulation, roles are assigned. So these roles are assigned in order to provide focus for the learner so that they know what to do when they enter the room. We also assign roles so they can learn more, so that we can learn more about the participants. Maybe somebody's lacking leadership skills, so we assign them that role so they can practice being the decision maker. Or maybe someone has trouble organizing their communication, so we assign them to make phone calls to the healthcare provider to give updates on the patient. Someone needs to document the care that's provided, so that role is assigned. Then, who's responsible for completing the assessment or interventions that are required? So roles are assigned based on the learning objectives of the scenario and the tasks or skills that need to be completed. Now, what becomes fascinating during the debriefing is the understanding that each of these people has a completely different perspective of what happened during the scenario. So the person on the phone may not have heard the primary nurse ask about spiritual needs. The person who's documenting care may not have seen the nurse assess the pedal pulse. And nobody may have seen the nurse glance at the monitor in an assessment of heart rate and rhythm. So it's for these reasons that perceptions are challenging to evaluate, especially when none of the participants see or understand the big picture. This is one of the fundamental reasons why debriefing is of such high value. So while perceptions are really important to understand, we must also keep in mind that they really don't typically match with the absolute truth in simulation. They do, however, give us great information that we can then use to improve our sim experiences. There are several areas that we need to focus our evaluation or assessment efforts on. I've categorized these areas into experience, participants, curriculum, and facilitator, and we'll talk about each. But first, the question is, are we assessing or are we evaluating? There's a lot of different definitions out there on the internet and in the dictionaries and the journals and the books, and a lot of them are contradictory. So we'll just leave that distinction to the experts, and for our purposes now, we'll just call them one and the same. So in the current simulated learning environment, we want to know if what we're doing is effective and how to measure it. So first we need to determine what it is. Now the next slide is familiar to most everybody in nursing simulation, but not so much in medicine, which is really a shame because it transcends all of healthcare education. For those of you who haven't heard, this framework, the NLN Jeffries simulation framework, has had a lot of background work done in the last 2 or 3 years, and it's recently been deemed a mid-level theory. So this really is exciting because it's the first and only theory that's specifically devoted to simulation. So this provides a good model for determining what parts of the simulation-based learning experience can be assessed. Now you'll see the framework is comprised of three spheres. The first holds facilitator and participant characteristics along with educational practices in simulation. Facilitator characteristics are broadly defined as demographics, while participant characteristics include program, level, and age. These are the ones that have really been shown to have a correlation with outcomes in educational studies. I do want to point out there are several parts of this model that are helpful as we plan our evaluation or our assessment of educational practices and outcomes. So first, when we're looking at evaluating the experience itself, the simulation design characteristics would be a good place to start. Now there's 5 simulation design characteristics included in the framework, and those are learning objectives, fidelity, problem solving, student support, and debriefing. So as we consider how to assess these characteristics, it's important that we use valid and reliable instruments. So first a note on that. Reliability refers to dependability and trustworthiness. This refers to the degree to which the measurement is consistent. That is, repeated measurements should give the same result. So stepping on and off the scale 3 times before you shower in the morning should give you roughly the same result, no matter how much you might wish that number were lower. Now, validity refers to the accuracy of an assessment. It doesn't measure what it's supposed to measure. You can see that if we try to measure the waistline of a person, we can use 3 very reliable measuring tools, but because of how they're designed, they're not all valid for this purpose. There's a lot of different types of validity. There's face validity, construct validity, criterion validity, and a few more, but that's really beyond the purposes of today's discussion. The objective that I want to reinforce today is that as we evaluate and assess, we want to do it with instruments of the highest reliability and validity. Those tools are out there, but sometimes a new one does need to be created, and I'll just share that that's not for the faint of heart. So let's go back to evaluating the experience. I wanted to share some examples with you today so that you have a place to start when you're considering how to evaluate simulation experiences. Now, the Simulation Design Scale was created by the National League for Nursing in 2006, and it has 20 items in 5 subscales. Now, the subscales match the concepts of the framework that we just looked at. The NLN supported the creation of this framework, so it pretty much makes sense that their tool follows along. Now, reliability and validity testing on this tool was not done until 2014. The reliability was good, but there was a lot of room for improvement in validity. So as for challenges for this scale, there's an item about fidelity or realism that asks if the scenario resembled a real-life situation. Well, how does the learner know that if they don't have very much experience? They might have not seen that situation. Another item, I was encouraged to explore all possibilities of the situation. Again, how does the learner know that? So the second part of the tool then asks students how important each of these design pieces are. Another tool, the Debriefing Experience Scale, also looked at the importance of each of the same items. Now, reliability was good for the experience part of the scale, but not the importance part. And the question that I ask is it important to know whether the learner thinks the item is important or not? How does the learner judge importance on a field that they are a novice in? Now, this tool can best be used to compare different levels of fidelity or differences in debriefing methods. The Simulation Effectiveness Tool Modified, this is an example of a tool that was created back in 2005, but it's just recently been modified. When I started working with the faculty at Chamberlain College of Nursing, I encouraged them to use this tool, and they really pushed back. They said it was outdated and they just weren't interested in it. Now, this was a tool I developed when I worked for METI, now CAE. to include in the program for nursing curriculum integration. So I really had a vested interest in it. I asked them to tell me more about their concerns, and when I heard them, I realized they were right. It really was outdated. But what followed was a really good lesson as it showed that just because a tool's published and it has established reliability and validity, that doesn't necessarily mean that it's still a good tool. So we took this one back to the drawing board. We made numerous changes to the tool based on the BSN Essentials, a document that's used to provide the framework for designing baccalaureate nursing curriculum, and QSIN, the Quality and Safety Education for Nurses competencies. We then did psychometric analysis of the updated tool, and we had excellent outcomes. This tool has 4 subscales: learning, confidence, debriefing, and pre-briefing. And the purpose of the tool is to gather learners' perceptions of how well their needs were met during the simulation-based learning experience. That data can then be used to make improvements to the experience and to evaluate simulation overall. The next area for evaluation is that of the participant. There are several tools available for this. The Creighton Competency Evaluation Instrument, called the CCEI, was used in the National Council of State Boards of Nursing study to evaluate how much simulation could replace clinical while still maintaining good outcomes. The tool can be used in simulation as well as traditional clinical experiences. It's in a checklist format and used to assess clinical competency. It's also based on the BSN Essentials and the QSIN competencies. The simulation thinking rubric evaluates higher order thinking such as critical thinking, clinical judgment, and clinical reasoning. This tool really struggled with attaining inter-rater reliability, or agreement between the raters using the tool, despite 6 hours of training. But this is a common challenge with rubrics, as they tend to be written too subjectively, and then not everyone interprets them the same. The Lassiter Clinical Judgment Rubric has been around since 2007 and was developed for assessment of clinical judgment. There has been really limited support for the reliability and validity of this rubric over the years too, but a lot of programs adopted it anyway because there was really nothing else similar out there at the time to use. Now, a literature review conducted in 2013 does establish validity of some areas of the tool, but inter-rater reliability continues to be a challenge. The Student Satisfaction and Self-Confidence in Learning instrument, developed by the NLN in 2007, it's included here despite the satisfaction piece because of its consideration of confidence. The psychometric testing of these tools was not completed until 2014 either, and it was found that there were some real problems with construct validity in the way the subscales were created. In fact, the statistical analysis showed them to be highly correlated, meaning they really weren't independent subscales at all, and they're measuring the same thing. So some suggestions were made as to how to fix the problems, but I really haven't seen that that's been undertaken or that there's even a plan to do that. Finally, the Spielberger State Trait Anxiety Inventory is a tool that's been around for years with a lot of literature about the reliability and validity of this tool. Now, state anxiety items include things like I'm tense, I am worried, I feel calm, where trait anxiety items include statements like I worry too much over something that really doesn't matter. Now, this tool is often used in studies that try to show that anxiety is reduced as a result of simulation. For example, when learners complete simulation experiences prior to going to clinical for the first time. Now, when the same person facilitates the same scenario for several groups of learners, it's often really easy to see where the curriculum gaps lie. For example, when conducting senior level critical care scenarios for nursing students, it became really clear that none of them knew how to use a non-rebreather mask. And they were going to graduate in a few weeks, so that was a little concerning to us. So when we really looked at the curriculum, here's what we found. In the very first week of school, we taught students all about oxygen delivery devices in the skills lab. Then they had med-surg clinicals, OB, peds, mental health, community, and then finally at the end, they had critical care. So over 2 years had passed. Why in the world would we think that they should now be able to recall this education? So as a result, we just brought the devices out again when they got to critical care. So that's a really easy example of evaluating curriculum through simulation. Now there's also a tool called the Clinical Learning Environment Comparison Survey, and this one is my doctoral work. Now at the time, the question of whether simulation could replace clinical was really just starting to gain momentum. And in my brain, in order to know if one thing can replace another, first you have to know how well they compare. So this tool asks nursing students how well they believe their learning needs were met in the traditional clinical environment and in the simulated clinical environment. Not surprisingly, most needs were best met in the traditional clinical environment, particularly those in the subscales for self-efficacy, holism, communication, and nursing process. The subscale items in the teaching learning dyad and critical thinking subscales were met equally well in both environments. Now this tool has excellent reliability and validity. The data from these surveys can be used to evaluate curriculum, as in where are we best meeting the learning needs. Maybe we're not meeting the needs well in either environment for some items. It also gives us curriculum effectiveness data to use for accreditation purposes and other reports similar to that. Knowing where we don't meet needs in simulation can then help to guide how we construct and implement our scenarios. If we know we don't do well meeting holistic nursing needs in simulation, then we can focus on improving that area. Finally, this tool can also be used as part of the assessment of simulation lab personnel and facilitators. After all, their role is to help meet the learning needs of the students. The results can help to identify faculty development opportunities also. Now, the debriefing assessment for simulation in healthcare tool has good reliability and some evidence of validity, but needs work done to see how generalizable the tool is. This tool is used to evaluate the debriefer and was developed by the Center for Medical Simulation at Harvard. It has been used around the world, and a database is maintained of results so that ongoing analysis of reliability and validity can be done. The Facilitator Competency Rubric is a tool under development. Now, currently, no such tool exists that comprehensively evaluates facilitators. When the National Council of State Boards of Nursing released their findings that up to 50% of clinical could be replaced by simulation, they did so with caveats about the skills and competencies of the facilitator. However, we don't have any way to measure that, so this tool is very much needed. For many, many reasons, data collection has been slow, but we're plugging away and continuing to extend data collection through 2016. So, moving forward, reliable and valid tools are out there and they're available. So, whenever possible, these tools should have preference over user-created tools. Sometimes, though, we need to look outside of nursing and the healthcare literature to find good assessment methods. The anxiety tool, for example, is found in the psychology literature. Creating our own tools sometimes must be done, but we do need to be aware that they may not be valid and reliable, and therefore, is it fair to use them to evaluate our learners? In some cases, yes, it's really not a problem, as within low-stakes assessment. However, the trend is moving towards using simulation in high-stakes testing, for example, for licensure exams. So if we're making decisions that affect people's livelihoods, then we need to ensure we're using valid and reliable methods. Inter-rater reliability is also a challenge, especially with rubrics. Even if a study has found good inter-rater reliability, it must be established again with your own raters. And if the study lasts over any period of time, it has to be re-established, sometimes many times, sometimes daily. So to wrap up, assessment or evaluation is a very important component of simulation. And we have the opportunity to learn a lot about our learners, our facilitators, the curriculum, and the experience itself when we do this. If you have any questions at all about the content that I've presented, please feel free to call or email me. Thanks so much.